want to start by thanking Sonia Rom and Rena Tam and the entire planning committee for all the work that's gone into this conference this week. It's been a big pivot, of course, from last year. For those of you all who joined us last year, we were able to be together and to network, and so pivoting to this format and thinking about how we build community in global health and rural and underserved health through this process has taken some creativity. But kudos to Sonia and Rena and the rest of the group who have sort of found ways creatively to bring us all together. This is an important space, and I'm really glad you all can be here today. So my name is Melissa Watt. I'm an associate professor in population health sciences. I consider myself a global health researcher and a researcher committed to health disparities research. And really thinking about how research can be used to advance community well-being, improve delivery of services, and can be done in partnership. So I'm really excited to bring together and have the opportunity to moderate a panel today of researchers from across the university health system who are really leaders in their own field and doing important and engaging work in global, rural, and underserved health. And the purpose of today is to share some of those stories and experiences and trajectories. And I think what you'll hear is that there are many different trajectories. And I think that is one of the takeaways, that there are many ways to engage in this space, to do this work, to forge your own careers. But I think that you'll find that there are also some commonalities. And I want you to pay attention to what I think of as the 3 Ps of the common threads of folks who are working in this space, and that's passion, perseverance, and partnerships. And I'm sure that all of the panelists today are going to mention the importance of these in different ways. And so I'll introduce the speakers. I'll introduce all 4 of our speakers first, and then we'll turn it over to them. This is going to be rather informal. We're not going to use PowerPoints. People are just gonna speak and have their videos on, and then we'll have an opportunity to ask questions and engage. So feel free as we go along to put comments and questions in the chat. We'll wait until everybody sort of has spoken. We'll give 5 or 10 minutes per speaker, and then I'll moderate some of the questions in the chat and then add questions as needed. So let me start with introductions. So first we're going to hear from Dr. Linda Edelman. Dr. Edelman is an associate professor in the College of Nursing, and her research focuses on injuries occurring to older adults living in rural areas, and thinking about the triage of injured rural and urban older adults to trauma care. She's the program director of 2 HRSA workforce development grants that are focusing on the geriatric research, the geriatric workforce, and really training a next generation of nurse researchers through teaching and mentorship. Our next speaker is going to be Daniel Lung. So Dr. Lung is an associate professor in the Division of Infectious Diseases, and he's co-director of the 3I Initiative, which stands for Immunology, Inflammation, and Infectious Diseases. And the 3I Initiative has really been a leader also in the global health space here at the U. There's a global health affinity group that comes together on a monthly basis to sort of share and support one another. Dr. Lung spent 4 years living in Dhaka, Bangladesh, working on diarrheal disease immunology. He did this after completing his clinical training, and I'm sure he'll share that experience and how it's shaped his trajectory. He's currently funded or been funded by the NIH, the Department of Defense, the Bill and Melinda Gates Foundation, and he works with collaborators in Bangladesh, Cameroon, DRC, Haiti, Mali, and Vietnam. The third speaker on our panel is Dr. Geeta Suneja. Dr. Suneja is an associate professor of radiation oncology here at the U and an investigator in the Huntsman Cancer Center. She also has an appointment in population health sciences. And Dr. Soneja is funded by a K Award that's looking at cancer treatment and outcomes of people living with HIV and cancer. She's done work both in the United States, really focused on issues around health disparities, as well as in global resource limited settings, most notably in Botswana. And the fourth speaker is Sudha Jayaraman. Dr. Jayaraman is a professor of surgery in the Division of General Surgery, and she is the director of the Center for Global Surgery at the University of Utah. Dr. Jayaraman has been funded by the NIH, Rotary Foundation, and the Department of Defense for both domestic and global trauma research, and she has a strong research program and partnerships with the University of Rwanda. And I'm sure she'll be speaking about building and sustaining that partnership in Rwanda. So we'll start, Dr. Edelman, with you, and look forward to hearing from you. And again, please just feel free to put comments or questions in chat that we'll get to later.
Thank you. It's good to see all of you here. And I guess it's appropriate that I go first because my research has really focused in Utah and the Intermountain West. And so I'll bring it close to home, and then it sounds like we'll spread out across the globe with the other panelists. So just a little bit of background about me. I grew up on a small farm in rural Kansas, and I am the first generation high school student from my family. So I was the oldest grandchild of about 30 some on the Kansas side. And I assumed that as I went through school, graduated from high school, went on and on to college, I just assumed that all of my siblings and my cousins would follow suit. And really, they did not. And there are 35 of us, I think there are 3 of us that have bachelor's degrees. And I tell the story because it tells a lot about some areas of rural America and the health literacy and educational gap that individuals in rural communities often have in regards to health and research. So one of the perseverance aspects that I would add to my suggestions on how you interact with rural communities is to always keep that in mind. And also to be aware that a lot of rural residents are really aware of that gap. And so they come to you with some insecurities about that. And so it's really important in how you address rural individuals, whether they're your patients or whether you're wanting to conduct research with them, because the last thing they want is to feel spoke down to. But I have kind of gotten ahead of myself. So I went on, I actually have a master's degree in experimental pathology. I did immunology bench work and then realized that I wasn't happy being in the lab. I really wanted to touch some bodies once in a while. So I have a master's degree and then went back to nursing school. And where nursing school led me was right into clinical research because I loved research. And so I did clinical research for the burn unit for about 17 years. And that is where my passion for rural research occurred. And that was because, I don't know if you know this about the burn unit, but the burn unit serves about 1/5 of the geographical US. So we had patients coming in from a huge area. And so there was a lot of disparities in regards to how those patients came to the burn unit, the length of time that it took them, whether they were appropriately transferred to the burn unit or not. And then there was the same issue on how do you get them back home? And if they had serious burns, how do you get them to their home community and give them the rehabilitative services that they need? I also, because of my background, have a real soft spot in my heart for farmers and ranchers. And my favorite burn patients were these 80-year-old farmers or ranchers who were out burning weeds in the ditch like they had done every day since they were 10, or every spring since they were 10. But now they don't bend so easily and they don't move so quickly, and they are shaky and they splatter gasoline on their pants and they start a fire, and stop, drop, and roll isn't really easy when you're 80. And all of a sudden, these very healthy, vibrant, active, engaged older adults are now 500 miles away on a ventilator in the burn unit, and they get septic, they have organ failure. All of a sudden, age catches up with them. And so it was heartbreaking to see how one injury could impact their life trajectory, and also maybe influence the fact that they were never going back to that farm or ranch, depending on the severity and the circumstances. So that led me into getting my PhD in nursing, and I did my dissertation on geographical disparities in burn injuries, and really came into the faculty with the idea that I was going to be this injury researcher. I continued for a number of years to partner with colleagues in the burn unit and Ram Narula on some of our injury research. But then I ended up getting into this workforce development aspect, and how do you train the workforce and support the workforce in those rural communities, which has led me into other areas of research more in line with access to care. But I loved, Melissa, the 3 Ps. I think that's so important. And so I'd like to just address those really quickly. Obviously, you have to have a passion, and you have to have a passion not only for the clinical aspects of the research that you're doing, but also for the people themselves. Because if you don't have that passion, the perseverance part is really hard. And so if you don't truly want to make a difference in the lives of people in rural or global communities, you're not going to be successful. You're not going to love what you're doing. And you have to love what you're doing, because perseverance is really the key, because rural communities are hard to get into, especially if you're not a native of that community. So some advice on forming those partnerships, which is also very important, is that you come to them with stories. I feel lucky that I can go into a rural community and talk about doing research there, and I can meet them on a common area. I'm a nurse, everybody loves nurses, that helps. But also, I grew up in a rural community. I know how to herd cattle, I can ride a horse, I know how to fix a fence, I can dress a chicken. I can really talk to them about I understand what it's like to live in a rural area. And so that's really important. And if you don't have that experience, you can find stories about your patients, or but just find stories that resonate with you, that you can share with them, that helps to start to forge a relationship. The other aspect is that when you're going into a new community, and I'm sure this is true on the global stage as well, you have to figure out who the right partners are. Because often the first people that you hear to contact are not necessarily the people that are going to give you inroads into that community. So you need to keep an ear to the ground about who are the key stakeholders, who are the people that communicate in that community. And that person who you may have contacted first may not have the trust of that community. And so it's really important that you find out who are the people that are trustworthy to that community, and that you make sure that you know them and that you have a good relationship, because they will speak for you and they will make introductions. And I think that that's really true in today's political climate, where there is a greater divide between urban and rural areas. We have preconceived notions about who lives in rural communities, and they have preconceived notions about who we are. And so it's important that you find that common ground that somehow avoids the political discourse, and that you form mutual trust and areas of where you want to improve health. So I think that's probably way more than 5 minutes. So I'll stop now, and I'll be glad to answer any questions.
Thanks so much, Linda. Daniel?
Thanks for this opportunity, and thanks, Linda, for sharing your story. Yeah, so I in terms of kind of empathy and really as that being part of collaborative work, I agree with those experiences on the applied towards the international and global health realm as well. I frequently, even if I don't have much in common with an investigator overseas, as sometimes I feel like the way that they're learning science and speaking a foreign language to learn it is something that I can empathize with them, because the English, I was an immigrant from Hong Kong to Canada, and that's when I learned English, and that really helped me to understand how some of the global health researchers internationally need to adapt to using English as to communicate their science. So I started really my interest in global health during my pre-med years. I did both a bachelor's and master's in pharmacology, and during that time got involved in infectious disease research, and then with that research background, I also had some clinical, and during med school as well, some clinical and educational experiences in international settings. And it was during that time that I realized that I was actually more interested in more of the research questions that came up through the clinical and educational experience in places like Belize and Peru and Angola, than probably the activities themselves. And I also realized that that great research can be done by in the places where the disease is endemic, and also that even if it's the disease that's the same, for example, hypertension, as exists in Canada or the US, that the research questions were frequently different. And so I ended up during med school taking a year off to do what I don't know if it still exists, but something called a Doris Duke Medical Student Fellowship. And I went to Brazil it was an Iowa-Brazil collaboration at that time. And I studied visceral leishmaniasis under a clinician scientist, an MD PhD, who's Brazilian and just was an amazing scientist, and really got to see how the questions can be answered, I think, so much better with patient samples that were analyzed and where data was analyzed in kind of down the road from where the patients were. So that was medical school, and then I did internal medicine and an ID fellowship, and I continued to have this goal of engaging in research towards kind of a globally important question. And obviously I did ID, so I was looking for infectious disease. And during ID fellowship, I found a mentor, and I looked for a mentor that had a good collaborative work and longstanding collaborative work with an international scientist in a lower and middle income country setting. And I ended up joining a cholera group. I really didn't think of, I never thought I would be doing diarrhea research, but it's ended up to be what my career is now based on. And it was really because of the mentor that I was attracted to, and his collaboration with his name's Ed Ryan, and with Ferdowsi Qadri, she's a immunologist in Bangladesh. And so, Melissa, you asked us to kind of bring up some challenges. And so my first challenge was, after I finished my ID fellowship, how was I going to get funding? How was I going to get my salary covered working overseas? And I want to be trained by a scientist in Bangladesh, so I needed to be in Bangladesh. So I think that's one, kind of my first challenge that I faced. And in the end, I applied for a bunch of grants, and my first year in Bangladesh, I got this Harvard Institute of Global Health grant. So it was kind of an internal one-year postdoc grant. And then after that, I was able to get an American Society of Tropical Medicine postdoc award, which funded me for the next year after that. And then finally, I was lucky enough to get a K08 while in Bangladesh. So between those three grants, and they're all training grants where it's proposing to train under this joint co-mentorship of the Bangladesh PI and the Bangladesh investigator and the Harvard investigator. Covered my 4 years in Bangladesh, and you can ask me more questions about that later. We were only supposed to go for 1 year, and then it kind of, my wife found something that she was very passionate about there as well, and so we ended up staying for 4 years. And it's those 4 years in Bangladesh, I was really able to work both under and alongside scientists and clinicians and epidemiologists in all kinds of settings, in the lab, in the hospital. I was able to bring some of my HIV skills there, and in helping to train some of the clinicians there, and also in the epidemiology front. And I think that really it really shaped what directions I ended up going in when I established my research program here in Utah. So after those 4 years in Bangladesh, we moved to Utah to set up a program here. And after coming here, I've been able to expand the kind of diarrhea focused research with Bangladesh, but also because of the connections I made in Bangladesh, really come up with new ideas and with investigators in other countries. And Melissa listed some of the countries that I collaborate with currently. And it really has been a big adventure. I can't say I planned any of this out, like the things that I'm studying, kind of using antibody responses, so seroepidemiology, using antibody responses to determine disease prevalence. I had none of those skills, and it's really working with partners that I've learned those skills way after my postdoc. Looking at clinical prediction and really engaging with clinicians on the ground, because we were looking at clinical prediction, we really, I had limited experience of what a clinician in Bangladesh or Mali or Cameroon, their kind of thought process as they treated diarrhea. So it was with help from my international collaborators, but also from domestic collaborators who've worked internationally, that help shape the research questions. So I'll probably just finish by saying that currently I'm doing 75% research and 25% clinical. I focus on tropical medicine and travel medicine clinically, and on the research side, being able to really dig deep into some of these questions around the immune responses to cholera, the antibody responses, the clinical prediction, and I think I'll leave with the one of the other challenges that I faced now that I'm a little more independent in my research, is how to set up and really have thriving collaborations that is funded by the U.S. or so NIH or Gates or DoD or Wellcome Trust, but that still addresses the research question that the investigator in the low-income country is interested in. I have certain interests based on my experiences in Bangladesh, but trying to make sure that we are addressing the true interest of my collaborators as well, but that also appeals to funding agencies. So I think my time is up, and looking forward to hearing from Sudha and Geeta as well. Thanks.
Daniel. Geeta?
Yeah, thank you so much. This it's always so wonderful to hear about other people's journeys, and I'm always taken aback by how much incredible talent we have here, right here at the U. And often so many of us collaborate outside the institution, but these kinds of things always make me think maybe we also ought to have more things like this where we can get to know one another and our backgrounds. So Melissa, thank you for the introduction. I am a radiation oncologist. I focus on treating patients with breast and gynecologic cancers. And like Daniel, I am a physician scientist. So I spend about 80% of my time on research and 20% of my time in the clinic. And my main area of focus over the last decade has been on patients who have both HIV and cancer. And a lot of my research program has focused on people with HIV in other countries like Botswana, Melissa brought up, but I know we have a lot of global, two other panelists with a lot of global experience to share. So maybe I'll focus on my domestic HIV pathway, because it is a population that's really underserved. And I'm happy to touch on, in the question and answer period, studying a population that's not as kind of common or prevalent in the area you live in. So there's not as much HIV here in Utah, but there's still been a lot of opportunities to grow my career and to serve this population. So I'll just start by kind of sharing a little bit about my background and pathway. So like Linda, you know, I think my interest in equity and health inequity in particular started from childhood. My parents were immigrants here to the US, and when I was growing up, they were in a period of life where they were studying. And so, you know, what we did, we really couldn't afford to do vacations and you know, a lot of kind of like extravagant hobbies, and we would save a lot of money so that we could take one big trip, and we went back home to see family to India about every other year. We'd spend the whole summer there. And I saw firsthand like these huge inequities, right, between the US and where we were going to visit our family, but then even within the area we were in India, seeing these massive inequities. And just, I remember trying to understand that, like wrap my head around what that meant, why that was the case. And then back home, you know, back in the US, seeing my parents really take the education that they had and apply it to careers in service, and really starting to think about, how do you serve communities? How do you make science a service endeavor? And so that was kind of the foundation. When I went to medical school at Brown University, which has a really strong social justice foundation for all of the medical training, and I really, really loved that. Like, to me, those were, you know, totally linked together. And that's also where I found my passion in radiation oncology. And I was learning about all these like interesting studies and different novel cancer therapeutics and how we cure cancer, but then also seeing that there are these huge groups of people who can't access that care. Both abroad and in low resource settings, but also right here at home in the US. There were groups that were really systematically excluded from accessing the very best care that we had. And so I became really interested in understanding, yes, how do we cure cancer, but also how do we make sure that everyone has access to those treatments and those approaches. And, you know, when I went, kind of touching on challenges, when I started interviewing for residency programs, I told people, you know, here, this is my interest. I'm interested in radiation oncology and I'm interested in global health. And people were like, what? That's not a thing. Like, you should go into ID or primary care, or, you know, it just wasn't something that people in the US were really focused on or talking about. But from my experiences having been abroad, I knew that people got cancer in other countries and that there was a huge need and that there were activities ongoing. They may not have been recognized by the US academic system in any formal way. And one of the things I hope we talk about later is this idea of kind of challenging conventions, you know, like, we look at papers, we look at grants, we look at these metrics that we ascribe value to, but are those really the things that are important? And so, you know, I just kind of went from place to place and said, here's what I'm interested in, until I found a place that said, okay, great, we like that interest. We don't have expertise in that area, but we will support you to figure it out. And that was the University of Pennsylvania. So I did my residency training there. They had a primary care program established in Botswana, and that's how I got kind of linked up with them. So piggybacking on an existing infrastructure was really helpful for me early on in my career, where I didn't have, you know, grant funding and these other kinds of resources. Using an existing structure to try to do some cancer work was really helpful. And that's also where I got really interested in HIV. That really came out of a clinical experience, seeing a patient with HIV and cancer and not really knowing how best to treat them, how best to offer care, how to handle side effects. And there wasn't a lot of information that was readily accessible in the literature. And it kind of got me started on this sort of two-pronged research program. One was focused on global oncology and one was focused on HIV. And I'll just talk a little more about the HIV piece. Basically, we did the first studies looking broadly at patients in the US who had HIV and cancer that showed that people with HIV were a lot less likely to get cancer treatment. And we confirmed this in many different data sets, many different cancer types, many different regions of the US. And for those of you that do any work with HIV, you know that the life expectancy of someone with HIV has drastically changed over the last few decades. And now people with HIV can live a normal life with normal life expectancy, very minimal treatment-related side effects. So when patients with HIV do develop cancer, they should be treated as anyone else would. So it's kind of shocking to see this huge difference. And we actually had trouble getting our first paper published because no one had ever shown it before. I think it was just something that people didn't understand, weren't thinking about. But really it spawned a large area, a research program for me. And now I think other folks who've become interested and involved, and has really led to exploring why we see these disparities and what we can do about it. And so after my residency program, I got a master's degree also from the University of Pennsylvania in health policy research. And that really helped me to sort of contextualize what I was researching. So it's one thing to study disparities and publish on disparities, but I felt like, and I learned from this program that, that doesn't necessarily help anyone. Other academics reading your work can bring light to a problem, but it doesn't actually do anything for the population that we were studying. So I learned how to take my research and make it actionable. Like, what can we do with this to actually bring changes to the population? And in the case of HIV malignancies, one of the big things we focused on is treatment guidelines. And so we worked really hard with the National Comprehensive Cancer Network, NCCN, to create a set of guidelines for people living with HIV and cancer. And it's, for me, was a way to sort of put action into the research and sort of bring it more to light. So nowadays, what I do, I like to think of health equity research as a continuum, from suspecting that there's a disparity to investigating it to exploring drivers of the disparity, and then the last piece, which is identifying solutions. And I think that's where a lot of health equity research falls short. We don't come up with or do research in solutions. And so I think that a lot of my focus has been on that piece lately. And I have an interest in health equity research, but I also have an interest in workforce diversity. And I do a lot of work in my professional society because I think those two things really go hand in hand. And so that's kind of where I'm at now. It's been a long, circuitous journey, which has been really enriching and really wonderful. And I touched on a couple of challenges, and hopefully we'll get to more of that in a little bit.
Thanks, Geeta. Sudha?
Thanks, Melissa. It's so great to hear everyone's stories and their paths. Mine has been just as unplanned and circuitous as our own else's. So 3 challenges I just want you to keep in mind that I'll kind of talk about. One is career path, the other is mentorship, and the last is funding. So I'm one of the trauma surgeons here. I'm new to the U, been here for about 8 months. I'm an immigrant as well as Daniel. And my family moved to Los Angeles when I was in middle school, and mostly to give me and my sister a chance at being more. And I went to college at Penn, and right before I went, my dad was diagnosed with cancer. He'd lost his job. He was the breadwinner for the family, and I almost didn't go to college. Because we couldn't figure out how we're going to pay for it. Managed to get past that hurdle. Got to college. It's like, what do I want to do with my life? Worked in a lab. Worked several jobs. Realized that the lab thing really wasn't me. Did some clinical research in the emergency department. And I was like, oh, you know what? The interaction with patients and really addressing patient issues was really a really cool thing to do. And I also there recognized the disparities in our health system, both looking at the trauma patients who are coming in, who are mostly young Black men who are shot, and watching them die was horrific. And that also motivated me to say, you know what, I want to do something about that. And then the other part was, hey, I grew up in a low and middle income country. The resources that exist in this health system here are so different. That helicopter brings patients to us, and you can't even find somebody who died from a motorbike crash for 2 days in parts of India, even today. And so the disparities were so stark. So when I went into medicine, I worked for a couple of years. My dad had died of cancer. It took a while to kind of figure out, up from down. And then went to medical school. I applied to medical school a couple of times, and we got in to one place, which is all I needed. And UC Davis took non-traditional students, which was really cool because actually I did it. One of my favorite rotations in medical school was a family practice rotation. This is coming from a trauma surgeon, in an Indian reservation in Northern California, and where I took call with the EMS team because I knew no one there and had nothing else to do after 5 p.m. when the family practice clinic closed. And it was amazing to see what the access to care challenges were in the rural parts of this country. And I still have a picture from that time hanging on my office wall to give me that perspective. But as I was going through medical school, I realized I loved surgery. There are 2 other physicians in my extended family of, I don't know how many hundreds of people, and I don't really know either of them. And so really, medicine in itself was new to me. And this interest in surgery is completely surprising. I thought I'd do something globally related. I was, having been an immigrant. So I couldn't figure out how to combine those two. Those are very different things, global health and surgery. And I had no mentors in either, really, and found that one of my chief residents in surgery had worked with a trauma surgeon from the University of Washington, who had done work in Ghana. And his work was training and assessing lay first responders and their ability to manage trauma patients. And training truck drivers and looking at alcohol use and looking at injury prevention in that setting. I said, oh my God, this makes so much sense. I know the burden of injury is so much more of an issue in the rest of the world. Those numbers really didn't exist then. It's much more recognized now that 90% of the world's trauma cases and trauma deaths occur in low and middle income countries. 95% of pediatric trauma occurs in low and middle income countries. We have beautiful trauma centers. We have dozens of trauma faculty. We have, burn centers. We have all kinds of things here that just are inaccessible in the rest of the world. And so really that's how I got into the research aspect. Did residency, did a public health degree at the London School of Hygiene and Tropical Medicine, got involved in some projects in Uganda through my residency at UCSF, and then went on to do my fellowship in trauma and critical care at the Brigham, where I got involved in work in Rwanda. And that's where my work has been in, for the last decade. And it's really looking at access to emergency services, access to trauma care, quality of trauma care, developing research around, developing research around implementation of checklists, standardizing care, looking at software development to address communications infrastructure. We just got a great review last week for a major 5-year grant that Melissa and I are working together on for Rwanda, and trauma research capacity, different grant I'm working on now. And that's been a journey. And it's been really hard in some ways because as a surgeon, I have to be clinical. I can't apply for a grant that's 50% FTE for research because I need to have my clinical technical skills. And so for the first 7 years of practice, I really was 80% clinical and another 50% research, which didn't do good things for my mental health. And so that was part of the reason why I came to this job, where I had a little bit more balance. I'm not 50% clinical, and able to kind of juggle that aspect and be able to get funding to support it from NIH and other foundations like Rotary and various things like that. So career path has been complicated, non-traditional. Mentorship was a challenge initially and continues to be. Nobody is really doing global surgery research. What does that even mean? Who are my mentors? And so that's a challenge even at this stage of my career. Funding's complicated because even when I went into residency and when I wanted to do my public health degree, people were like, why would a surgeon need a public health degree? What is that? I mean, why would you get an MPH? Why do you need to look at clinical outcomes? And that doesn't even make sense now. People would say that 15 years ago. So there's some real challenges there that I had to kind of figure out how to navigate to start my research academic career. So with that, I'll turn it back to Melissa.
Thank you all. This was fantastic hearing this, and I think also really inspiring. And I would add another P. It doesn't begin with P, but it has two P's, and that's opportunity, because I think all of you sort of talked about opportunities that arose, that you recognized, that you took advantage of, and that took you in unexpected directions. And I think, I think too often, I think younger trainees or sort of, early scholars kind of look at folks like you all and think, oh, they must have had this sort of laser focus on their, to get to where they are. And in fact, I mean, all of you kind of describe a much more serendipitous approach where you're taking new directions as new opportunities arise, as you're identifying new needs. I mean, Geeta, I really like how you were talking about also identifying areas that are unconventional and not recognized. I mean, same for you, Sudha, like, global surgery. I mean, when you went into surgery training, we didn't have global surgery conferences and a global surgery community. And you've been building that, and same with global oncology. And so I think, I think that's sort of another common thread, even as it's uncommon across everyone, or it's very different across everyone. So I want to encourage people, we have 15 minutes for discussion, to put questions in the chat that you want to ask to the panelists. And I'll just start it off as people are adding questions, and that's to ask you all to kind of think about what advice you would have for trainees. So particularly, this conference is targeting GME trainees, so residents and fellows who might have an interest in going into rural underserved medicine, into global health, combining those two. What is kind of a piece of advice that you would give, maybe something you wish you had known or thought of when you were a trainee, or something you've learned along the way? Anyone want to start with that?
So Melissa, I think, people have touched on this, but I think what I would say, the number one thing I've learned, and I think the number one thing that's contributed to the advancement of my area of research, is to center the population that you're working with. And, for me, that's been working with community advisory boards, people, HIV advocates, people who are, Linda talked a lot about how identifying with the population is really important. And I think that sometimes that's from a shared background, and sometimes that's from just really enmeshing yourself in the environment, whether that's living in the country that you want to work in or study in, or partnering with people who do have that like insider knowledge. But for us, that's been so critical. Like, number one, to make sure the things that we are trying to investigate and look at are relevant, are going to help the population, that, and then also just in terms of like amplifying, including, sponsoring the very people that you're working with. That I think has been like a guiding principle, and something that I've seen not go well. And when it doesn't go well, it's very difficult for everyone who's involved.
Yeah, thanks, Geeta. And Daniel, you spoke to that earlier about how you make sure your research is responsive to local priorities, particularly given funding challenges, research priorities. Want to add to that?
Yeah, and I guess, well, I was going to jump in with this slightly different point, but to add to Geeta's point, I think frequently I come away from an experience with what I think the research questions are, but I am surprised by the research question that my collaborator actually is more interested in, and sometimes I'm right on, or sometimes I'm way off, and it really helps to have a collaborator shape that research. I do want to mention on a more practical side for the trainees who may be looking at in the near future, or maybe the far future, starting your own research program, and during a training to develop skills, generate preliminary data, and maybe even get small grants so that an institution would invest in you. Many of us who start research programs, whether it's $100,000 or a $2 million startup, there are startup packages that you need to start your research in your institution. And I think something that I wish I knew when I was a fellow was that what I end up, the skills that I'm building and the collaborations and the papers I'm writing contribute towards an institution's search committee's evaluation of me, whether to give me money to start a research program, or how much. And I was fortunately guided by mentors who helped me kind of steer me towards the track that would get me a research, that would make me competitive to start a research program. But I don't, I mean, obviously that my track is not the only track, and we've had many different tracks that on this call, but that's just one consideration, is to kind of think of the skills and the collaborations and that you're bringing to the table when you get your job, or when you're promoted at your job, and get more resources and ask for more resources.
Great. Thanks, Daniel. Linda, you want to add? Want to add anything in terms of pieces of advice you would have?
Sure. I think one of the things, and I agree with everything that both Daniel and Geeta have said. I think one thing that you mentioned, opportunity, I think that's really key, is you need to keep a lookout for who's doing work in whatever area of interest it is. They might not be in your institution, they might not be in the same country, but you need to keep an eye on what people are doing and gain ideas. And then, especially these days, you can reach out to anybody, anywhere, and brainstorm with them and help get your ideas, talked through and thought through, and get that support. And I think that's invaluable. You'll be amazed how many people will say yes to even just talking to you for a half an hour. That's really, really important. And it'll give you the direction. So look for those opportunities, look for those mentors, and reach out to them, and you'll be surprised at what you get.
If I can add one other thing, it's about taking advantage of opportunities that are showing you. And I'll just tell you a story about a misstep that I had. I was doing a research study in Carbon County in Price, Utah. And Price was a area that had a high rate of injuries. And so I was doing both a quantitative and qualitative, a mixed method study there. And I was interviewing older adults about their perceived injury risks in their home. And over a third of the older adults that I spoke to talked to me about their concern about family members or neighbors stealing their medications from them. And this was like 14, 15 years ago. And I'm like, no, I'm interested in traumatic injuries. I just went la, 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 just kind of let that pass over my head. And today, to this day, I kick myself, because for those of you who aren't familiar with Utah geography, Carbon County is a hotspot for opioid misuse. And I feel like I was given a canary in the coal mine that I totally just let die in front of me. And I didn't do anything about it. And I've circled back, and I now do some work with the Opioid Coalition, et cetera. But I keep thinking my whole research trajectory could have changed right there if I would have paid attention to what that community was telling me. So keep your ears open and pay attention to what they think is important. You know, I was a new researcher and I was just focused on injuries and falls and didn't even pay any attention to this other aspect of their lives that they were really worried about.
Thanks. That's a great point, Linda. And it speaks to what Gita was saying as well about centering the community and thinking about how you can continually be responsive. There was a question in the chat about getting skills, and I think particularly skills around research design and research practice and data analysis and data collection. I wonder if people if anybody wants to talk about, I mean, you all are all clinicians. I don't know if clinicians first is accurate, but like, you know, your clinical work is a really important part of your jobs. And how did you build that research skill set then to step into the research world? And how much of that, I would be curious, kind of comes from didactic training, and how much of that came from mentored experiences and just kind of diving in there and being part of research projects? Anyone want to speak to that?
Yeah, you know, I think for me it was both. And I actually think, I'm just reading Dr. Powell's question. I think it's totally fine to have not been as enmeshed in this kind of stuff during your clinical training and then to come back and do it later. And in fact, I would argue that in some ways you will do it with more intentionality when you know why you're doing it. You know, like, I'm really glad I did my master's after my residency. That's a little bit less traditional. A lot of people do it in medical school, in preparation for something they want to do in residency, or some people do it as part of their residency. I actually did it after, when I was faculty, but I knew exactly why I was doing it. Like, I knew what skills I needed. I knew what skills I had. For me, I had a lot of the quantitative skills, and our training in RadOnc is very focused on like statistics and things like that. But I didn't really know anything about implementation research, you know, implementation science, surveys. Like, those were the things I was looking to the skills I was looking to acquire. And then similarly, my career development award, I applied for and got very close to the end of my eligibility period, which some people would argue, you know, why even do that? Like, you don't need to do that at that phase of your career. But it's been so helpful, because at this phase, I needed skills in qualitative and mixed methods research. And Melissa's been like an instrumental collaborator and mentor in that regard, but that's what I needed to learn. And for me, it was all new. So I think it's totally fine. And I hope for the rest of my career, I can do something similar, where I can identify where I need skills and then engage in different kinds of training programs, whether they're formal or informal, to help.
Yeah, and Gita, I think that sort of also links to what Sudha was saying earlier. I mean, Sudha, you're a full professor, and yet you're talking about the need still to have mentorship, right? I mean, I think that doesn't end, and that, you know, it's a continual learning process, and that we all need partners and to be continuing to build a skill set, and not be afraid, as you said, Gita, to like branch into new areas, not to get stuck.
I'll just add, I have a master's, but it was before medical school and has nothing to do with what I do right now. But and I learned pretty much everything on the job. But it's why I did a postdoc after my fellowship. You know, the 4 years in Bangladesh was all training, and it was all training under under the operating funds of somebody who, you know, had the NIH grant, and I think that the such a postdoctoral period is not frequently used by many clinicians, but those opportunities are out there. That fellowships are not only clinical fellowships; there can also be research fellowships. You know, right now I hold a grant where, you know, a couple of grants where there's funding for postdocs, and I'm hiring non-clinician postdocs, but those same slots could fund a clinician postdoc if they were interested. And that postdoc could get training, both didactic, but mostly non-didactic, in research methods that my team is working on. And so, and I don't think I'm the only. I mean, there's many those types of opportunities around. So, and I think a lot of people would very much like to get a clinician, or well, it may be attractive to be a clinician for some of the research projects out there, and postdoc opportunities. And there's also T32s that would fund clinicians postdoctoral years. So I think there are many approaches, and you do not necessarily need a kind of formal didactic session, but just jumping into a research group, being a postdoc is one way.
Great. And I mean, several of you have mentioned mentorship as well, and mentorship across different phases, and the importance of finding that mentorship. And I would just add, I think mentorship is most effective when it is a give and take process. And so finding opportunities for mentorship where you're contributing to a research program and learning through that process and getting support and feedback through that process, I think is the most valuable way to develop meaningful mentorship relationships. So we have reached the end of our hour. I want to thank all of the panelists, and thank you all for participating. I know that I found this really inspiring, but also, inspiring at an individual level, but also inspiring in terms of the wealth of resources that we have here at the U, and the wonderful people we have here at the U. And I think, as you all mentioned, we have a lot of opportunities to collaborate here across our institution. And thank you to the Surge Committee for creating these opportunities for networking and learning from one another. And I would just, in closing, turn your attention to the chat. Rena and Sonia put in at upcoming events for the Surge conference. I don't know if you want to add anything, Rena and Sonia.
No, but just thank you for all being here and just starting these discussions. I love that this is recorded, and we're just so excited to get this out to all of our trainees, and they can just see what we're doing across health sciences on so many levels, and just really great practical points of advice and inspiration that I think I wish I had heard when I was a resident here. And so I just appreciate everyone being here to hear this, and please distribute once we get the recording out. As always, your feedback is really important to us for when we plan for next year. So we want to keep this research discussion on the docket for next year. So would love your feedback.
Great. Thank you all.